So, second, let's see who we got. We've got Rod. I think Mohammed's on vacation. Christina and Kitoki. We have Molly and Maya. Okay, I think we're good. All right. Guessing. Okay, here we go. All righty. This is a tracing from patient who has a pacemaker. So my question to you is, what kind of pacing do you believe is going on here? And why is this patient paced, do you think? And what do you think is wrong with this patient? What is the diagnosis? So why don't we ask Dr. Kalis if she has any thoughts on this tracing?
All right. Good morning, Dr. Pass.
Good morning.
All right. So looking at this tracing, it looks like we are pacing the atrium because I am seeing the pacing spikes before the P waves.
Uh-huh. And let me just add, and a P wave after every pacing spike.
Yes. Yes.
Okay.
And a P wave after the pacing spike.
How do you know it's not AV pacing? Or what would hint to you that it's not AV pacing? It's not, but I'm just
Well,
asking.
if it was, I would expect to see both two pacing spikes, like one after the P wave and also one before the P wave and also one before the QRS.
Okay, I agree with that statement. Any other clues to how you know you're not pacing the V?
Where
do we normally place ventricular pacing leads in patients?
In the RV.
In the RV. And if we pace the RV, what is the morphology of
then the QRS is usually wider.
Yeah, and it usually has a left bundle morphology. Unless, of course, we're doing some kind of novel pacing like left bundle pacing or his bundle pacing. But in typical traditional pacing, we would have a left bundle. Okay, so I agree. This looks like a pacing. So do you have any thoughts on what the diagnosis of this patient might be and why there is even a pacemaker at all?
So just checking the rate, about 75 or so. So a diagnosis could be complete heart block, or I'm sorry, not complete heart block, but if there was any sort of like sinus node dysfunction and like sinus bradycardia, and we felt that we needed to pace the patient at a faster rate as to whatever the underlying rate may be.
Right. Any thoughts on why this patient, based on this electrocardiogram, might have a slow heart rate and need an atrial pacemaker?
Let's see, checking. Looks like the axis is about 0. Based on this EKG.
So the P wave axis is normal. The QRS axis is close to normal.
Yeah.
About the T wave axis, is that normal?
I mean, there's T wave inversions kind of all throughout, except
Yeah, is
kind of
that a
everywhere.
normal pattern of T waves? Do they look?
No.
What do you think about the morphology of the T wave and the QT intervals? And
So it's a pretty broad T wave, so long QT, so could have some sort of
look at lead one. Look how long this isoelectric period is before we see the T wave. Similarly in lead two, right? There seems to you sort of get this very late peaking T wave. Um, so any thoughts on what this diagnosis with this unusual QT morphology might be?
I think with type 3 long QT syndrome, you can have that late peaking T wave.
Right. So first statement is, I guess you're saying you think the patient may have long QT syndrome. Is that, am I surmising that right?
Yes.
Okay. And so yes, you are right that, there are some resources that will suggest that based on the morphology of the T wave, you can guess what the patient actually has, meaning long QT 1, 2, 3, or 4, the main ones, although there are now, of course, I think 17 genetic varieties that are known, constituting roughly 80% of all long QT patients. However, so I would agree that the first statement is it's probably long QT syndrome. Now, one of the things I want to just draw everyone's attention to is the QT isn't very long, right? And I think maybe, is that possibly, Maya, why it didn't sort of jump out at you initially as long QT?
Yeah, like just kind of eyeballing it, I guess in some it looks like it's less than half the RR, which is kind of my
Right. Well,
initial.
that's a good reference, is usually if your QT interval exceeds the RR interval, that almost always is consistent with that diagnosis of long QT. Good rule of thumb. But this, I think, is a nice example of how somebody can have long QT. This patient does have long QT syndrome, but how one can have long QT syndrome and not necessarily have an obviously very long QT. It turns out this QTC is not normal. It's probably, or maybe it's the very top limits of normal, lower limits of abnormal. Maybe it's like 465, 470. But the point I'm trying to make is that the T wave morphology and the QT morphology are very abnormal. You have T wave inversions in many of the precordial leads, which we've discussed in the past, can actually more traditionally be associated with hypertrophic cardiomyopathy. So whenever you see T wave inversions, particularly in these left lateral precordial leads, such as V3, V4, V5, V6 in this case is upright, and this is sort of isoelectric. You always want to at least think about hypertrophic cardiomyopathy, but you don't really have very large forces here. But you can get unusual morphologies of the T wave and the QT interval in people with long QT syndrome. And so the point I'm trying to make with this tracing is simply that, one of the benefits of looking at as many electrocardiograms as you can is sort of just some pattern recognition. And these T waves are very, very AB normal, right? I mean, look how late peaking this T wave is here. This is unusual, right? To have almost 300 milliseconds of isoelectric period before you see a late peaking T wave. So that would be very suggestive of a disorder of repolarization. Why do you think this patient with long QT syndrome requires atrial pacing, Maya? Like, would we normally put a atrial pacemaker in somebody with long QT? So the treatment of choice is what for long QT syndrome, first of all?
Usually the initial treatment would be a beta blocker.
Right. That's the only agent that has been definitively demonstrated to reduce the risk of sudden cardiac arrest in long QT syndrome. There is some controversy regarding long QT3 or sodium channelopathies about the efficacy, but I think even in those circumstances, most electrophysiologists and cardiologists would recommend using beta blocker, although perhaps in that setting, you might use propranolol as opposed to nadolol because propranolol has a little bit of sodium channel blockade as part of its mechanism. It's a very weak sodium channel blocker, but it might be marginally better. But okay, so all right, so you would use propranolol. This patient happens to be on a nadolol, which is a reasonable. Remember, we've discussed that non-selective beta blockers are preferred in people with channelopathies. I think actually Christina reviewed that for us in Journal Club 2 weeks ago. Uh, so um, so would that explain pacing, do you think? Or
Not
could that?
really. Maybe this patient, um, if they had like an arrest and needed to have an ICD placed,
Mm-hmm.
maybe with the ICD there was like a backup rate that was set, and if this patient was bradycardic, maybe they triggered atrial pacing.
Yeah. So that's basically right. That's a good guess there, Maya, of based on knowledge. Good job. So the first thing to say is, people often think that and some of you have heard me say this in clinic, that the bradycardia that's associated with beta blockade is actually the effect that is causing protective benefit of beta blockers in long QT syndrome. That is actually not true. If we had the effect is more on the effect of adrenergic tone on the heart, and the bradycardia is really just a side effect of the beta blocker. And interestingly, people with long QT on average are more bradycardic, separate from the beta blockers. It's not uncommon that when you meet a patient with long QT that their heart rate's a little on the slow side. And then you're giving them a powerful negative chronotrope in a beta blocker. And so sometimes patients will become quite bradycardic. Now, electrophysiologists and cardiologists use the bradycardia associated with beta blockade in long QT as a sign of how effective the beta blockade is. So we essentially use the bradycardia as a convenient side effect that allows us to know if we're on enough beta blocker. And so typically one would do a Holter or a Zio patch in order to quantify what the average heart rate is and to look at the degree of heart rate variability. And we would like to see that patients who are well beta blocked can't really raise their heart rates very high, and maintain their heart rate in a relatively monotonous and slow zone. And the other thing that is routine in long QT patients is to do stress tests every once in a while. Typically, I do them every few years, although sometimes more frequently if the patient is growing a lot. This patient is actually an adult already, but someone who I've taken care of for a number of years. And um, and so basically you would want to do a stress test every once in a while just to reconfirm that at maximal exercise, the patient's heart rate doesn't exceed a certain level. And so Dr. Arnon always knows that a lot of my patients who I send to her have long QT, and I'm looking specifically for that. And when I walk through the door after the test, the first thing she'll say to me is, "Your patient is very well blocked." And she's referring to the fact that the heart rate doesn't get very high. I think in this patient, the maximal heart rate with a recent stress test was something like 117 or 120 or something like that. But sometimes these patients can become so bradycardic that they don't feel well because of chronotropic incompetence. Remember that the most common way that human beings raise their cardiac output is by enhancing or increasing heart rate. And so this patient actually presented with an episode of torsade as a small child, and interestingly, was started acutely on an esmolol drip, but continued to have little runs of VT intermittent with sinus. And it was only when we added lidocaine to the beta blocker, to the esmolol, that the VT stopped. Also, it was observed by me that, that just like Maya said, this late peaking T wave was at least suggestive of her having a sodium channelopathy. Although interestingly, she had tested for a different form of long QT that was not a sodium channelopathy. Basically, because the patient had even though they had a genetic test consistent with, I think it was long QT1, we decided to not only put the patient on beta blockade, but also to add mexiletine, which is a sodium channel blocking agent, as we know. And she has remained, or he has remained on this regimen for the last, 2 decades. and has never had an arrhythmia recorded. Also got a defibrillator because of the very dramatic presentation. Thankfully, this patient, although fainting, never actually arrested or had cardiac arrest or sudden cardiac death attempt. Interestingly, on this regimen, has never had a documented arrhythmia in nearly 2 decades, but definitely did present that way. So, and one of the things that we're going to do in this patient is retest them because the testing was done so long ago, genetic testing, that it's possible that maybe there is a sodium channelopathy that was not yet discovered at the time that the initial testing was performed. And so that's what's going to happen in the near future. Any questions about this? The interesting thing about this patient is that when the ICD was implanted, it was just a single chamber device. But because of the patient's complaints of being tired, at the time of the generator change, we upgraded the system to a dual chamber device, and it has remained a dual chamber device ever since. Now, one could argue that I am pacing the patient too fast. I mean, does an adult really need to be at 75 beats per minute? But what happened, this actually is a AAIR pacing. And so this heart rate is related to some kind of physical activity coming into the hospital or climbing upstairs or something like that. So presumably the device sensed the activity and raised the heart rate. This is not actually the lower rate limit that is programmed in the device, but remember that with rate responsiveness, the computer of the device slowly raises the lower rate limit in response to activity, either more or less. Okay. Any questions about this? Okay, we'll move forward. What is this rhythm? Why don't we ask Dr. Kitaki what she thinks? 2 weeks in a row, I've asked Katoki questions. So next week you'll be off, Katoki.
Thank you, Dr. Paz. Good morning, Dr. Paz. I'm looking at the rhythm strip at the bottom, V1 at the bottom. Can see a P wave not followed by a QRS, then a P followed by a QRS, then a T.
So you're saying this is the P wave?
Yes.
Okay, and then this one.
And then another one and no QRS.
Mm-hmm.
And then I see a QRS with the
There
P
may be
wave.
a P wave in here, right?
Yeah, P wave there, and then a P wave and a very long PR interval and a QRS and P wave, no QRS. So and then a P wave. So I think there is like desynchrony between the P waves and the QRSs.
This is a new term I've not heard before.
Dissociation.
Desynchrony.
I meant they're not. There seems to be AV dissociation, and
So is it first degree
it's
block?
no. So this appears to be.
Is it third degree heart block?
I think it is.
Okay. I'm going to suggest that. So now, one of the things we've talked about complete heart block or third degree is what's typical of the RR interval that we've discussed?
They're usually like they're usually same. They're usually similar.
Yeah,
but
at least on a tracing, on a given tracing of 12 seconds, which is what a 12 lead ECG is, the RR would be the same. Is the RR the same in this?
No, it isn't.
It isn't, right? I mean, and where I think you're noticing this beat, right?
Yeah.
Is this R to R interval is a little shorter, right, than this R to R interval?
Yes. Yeah.
And is also shorter than this R to R interval.
Yeah.
Then again, this RR is kind of similar to this RR, right?
Right.
And is a little shorter, right?
Yeah.
So, and you actually made the observation when you were describing it that the PR was longer, and I thought you maybe were trying to imply that maybe there was some conduction here. Is that what you were?
Yeah.
So this is not it's first degree, and we've now established it's not third degree, right? So,
Yeah.
so this is second degree heart block.
Yeah.
It's the only option left. Is it Mobitz 1 or is it Mobitz 2?
I think let me try. I think it's Mobitz 2.
Yeah, I think we would probably have to call it that. I mean, without a His catheter in place, it's hard to know for sure. Also, but we do have, a couple of P waves in a row that are not conducting, right? This one doesn't conduct. This P wave doesn't conduct, although the coupling interval between, we're still in repolarization here. So this is it's unfair to expect that this P wave would conduct. This would not conduct in any of us. If it fell at that point of the QT interval. Yeah, this is probably, another way to say this if you want to protect yourself is just to say this is some kind of high grade second degree AV block. But it's not complete heart block. And now, if this patient walked into your office with this finding, what sort of evaluation would you do, Katoki?
I would do an EKG. Sorry, I have an EKG. I'll do an echo to look at the function.
And why are you looking at the function? I'm in agreement with that statement, but why?
Because if it's a high grade second degree heart block and then all the P waves are not conducting,
Yes.
I would be, and is
What
this also,
disease state are you looking for on the echo?
I'm sorry?
I said you're doing an echo
Yeah,
presumably because you're worried you're going to find something on the echo. My question
yeah.
is, going into the echo, Melanie takes the patient and she says, why are we doing this echo? And you're going to say, well, the patient has heart block. And she's going to say, well, but what are you looking for? So my question is, what are you looking for? Echo is correct. I'm just interested to know what you're looking for. What sorts of things can cause this? You mentioned function. Why would the function potentially be bad in such a patient?
Is this associated cardiomyopathy?
Okay, you could have a cardiomyopathy that also has some kind of heart block. That would be bad luck, but yes. Are there any inflammatory diseases that could cause this?
Like if there's myocarditis.
Right, you could have an infection like myocarditis causing this. What else could, what other infections? So when we speak about myocarditis, we're normally speaking of viral infections.
Yeah.
The other types of infections that can cause higher grade AV block?
I mean, Lyme's disease can
Yeah,
cause, yeah.
sure, Lyme disease could. So that would be the most important things you'd be looking for. What kind of things would you ask in the history of this patient? So presumably, let's pretend that this patient says they feel okay. Like this was, the pediatrician heard a slow heart rate and referred for that reason.
I would ask, yeah, sorry.
Go ahead, please.
I would ask them about other symptoms, like whether they've had pre-syncope or syncope.
Okay, patient says they feel okay. Not really. Anything else?
Um, if I would ask them, like if I'm ruling out Lyme's disease, I would also ask them if they had like Lyme's disease related like history, where they've traveled anywhere where.
Right.
Yeah.
Certainly want to ask if they've been in a forest-like area. And of course, in our area in New York City, you would think not, but we're close enough to a lot of areas, including being close enough to Lyme, Connecticut, that could be a thing. But it seems in my experience, whenever I ask that question, they always, say, well, we were at the park in the Bronx, but not usually out there. But sometimes people, of course, travel. And you'd want to know, right, if patient had fever or things of this nature, right? Now, any other testing you would do? So I agree fully with the decision to do an echocardiogram.
And so is this the first time they're presenting in my clinic?
Yes, because presumably you would do these tests. And is there any other history you might want to ask?
I've asked them if they've ever had an EKG before elsewhere, and
Okay, the answer is not that I recall.
okay. Um,
Anything you might want to ask the mom.
like if she has, I would ask her if she has a history of lupus.
Yeah, lupus or any connective tissue disorder associated with antibodies.
Yeah.
You know, it's not uncommon that the first diagnosis of a connective tissue disorder in a woman is when their child presents with this type of electrocardiogram. So not uncommonly, almost always the answer is no, I don't have lupus, not that I'm aware of. And I always suggest to the mother that they ask their primary care physician to send an antibody panel on them. You know, you obviously have to say that with a little bit of tact. You don't want to alarm a woman that she has a potentially serious disorder. But on the other hand, it would be important in order to understand the etiology of this. Additionally, you would want to know this because it would have an impact on future pregnancies of the mother, if that was in the cards for that individual. So, yeah, because it could be that there's lupus antibodies. You know, we always think about complete heart block as coming as a result of maternal antibodies, but you don't have to have complete block. You could have any form of block can be associated with it. Complete is obviously the most serious and worrisome variety. Um, so any other testing you might do though?
I would do a Zeo,
And what are you
just
looking for on the Zio? I agree 100% with that decision.
I would like to see how the heart rate trends in this patient. It's pretty low now. It's 40. I would like to see uh, uh, how
Okay. And
what the
what
heart
are you
rate.
looking at? I agree. You want to see the trend. Why are you looking at it though? What is there anything you want to know about that trend? We know it's going to be slow, right? Because the patient seems to be in heart block, some sort of heart block, second degree. Um, you want to look at the average heart rate, right? Because there are recommendations from the ACC, AHA, and HRS groups on how slow is slow enough. This is a gray area because it's second degree block. And one of my mentors, Dr. Hordoff, used to say that this type of block, high grade second degree block, was more worrisome to him than complete heart block. And the rationale for that statement was simply that we know that people with complete heart block usually have a certain pattern. Once they're complete, we know that if it's going to get slower, we know what the general progress of that is. We know when pacing is usually indicated for that disease. And it's uncommon that one goes from like an average heart rate of 57 to an average heart rate of 14 in a year. It tends to very slowly get slower. But in somebody with Mobitz 2 block, we just don't know if we don't have a good explanation for the etiology, which, by the way, is the majority of these patients after doing all this testing. We also don't know what the natural history in this individual patient is going to be. And so the concern is that, you know, maybe there's higher grade block at times, maybe there's a wide QRS escape rhythm, maybe this, you know, you can have so-called pause-dependent ventricular tachycardia, which would be considered an indication for a pacemaker. So you want to make sure that you're not seeing when the patient is, this is of course obtained awake, but when the patient is sleeping, are there like 9-second pauses during which time there are short runs of VT? That would be a very worrisome finding, which would warrant implantation of a pacemaker. And then one thing we didn't mention, just to be complete, is we would want to check the patient, do a physical exam of the thyroid gland, make sure there's not a goiter or nodules that you feel, and you would probably be smart to do a basic thyroid screen blood work to make sure that there's not thyroid disease, which can cause block. And I've only seen that one time in a patient of mine who actually was known to have hypothyroidism and just wasn't actually, interestingly enough, this patient had hypoplastic left heart syndrome, had congenital hypothyroidism, had been on thyroid hormone replacement her entire life, and came in as a teenager and was in Mobitz 2 block. And I asked the patient in front of their mother if they were taking their medication. The answer was absolutely. And then I got a phone call from the car on the way home that she admitted that she was not taking her medication. And in actuality, with resumption of her thyroid medication, the conduction recovered perfectly. So, but hypothyroidism is always in the screen. But I've yet to make the diagnosis of hypothyroidism as a result of the ECG, whereas I have made the diagnosis of connective tissue disorder in mothers of children with this when this is presented. But maybe I've just been lucky or unlucky. All right, any questions about this? All right, I think we're going to stop now. Thank you all very much. I hope everybody has a great day. As an FYI, on Thursday, Sam Menahem from Australia may be visiting, and so either on Thursday we'll do angios, or Dr. Menahem may be giving a lecture. I'll let you know, but either way, we're on for 7:15 on Thursday morning. So I'll see you then. But of course, I'll see you all before then. Have a good day, everybody.
Bye, Dr.
Thank you.
Bye-bye.
Thank you.